This case is a little different slant on hemolysis. This was a 70-year-old woman who had a 40-year history of multiple sclerosis, so she had an autoimmune disease. She also had a history of mitral valve prolapse and deep vein thrombosis. She came into the hospital with dizziness, shortness of breath, palpitations, nausea and vomiting, and a urinary tract infection. And her admitting hemoglobin was only 7.7, and going back through her medical records, it had been as high as 13 just 2 months prior. The day after she was admitted, her hemoglobin fell another 1.5 grams down to 6.3, and so the physician ordered 2 units of red blood cells. Well, we worked her up in the blood bank, and we found that she was A positive and that her antibody screen was positive, meaning that she already had red cell antibodies circulating in her blood. But also the direct antiglobulin test was positive. Now, the antibody screen tells us that you have antibodies circulating in your plasma. That usually comes from either pregnancy or from a previous transfusion. But in this case, she also had antibody coating her red blood cells. Usually that indicates it's an autoantibody, and this patient has autoimmune hemolytic anemia. What I don't like to see is when we have both, because that indicates that she has an autoantibody which reacts with every kind of red blood cell. But then we have to also figure out, does she have antibodies from previous transfusions or pregnancies, and we have to make sure that we find blood that's compatible and won't react with those antibodies. So we have to go through all kinds of elaborate testing in the blood bank, and what we found out was that she truly did have a warm autoantibody, but she also had an anti-little c, Rh little c, and an anti-Rh big E, so she did have both the alloantibodies and the autoantibodies. So then we have to do a bunch of different studies where we absorb out the autoantibody and then find units that are compatible with that plasma, and then we issue that. Well, we finally got the blood compatible, and we issued it about 1:30 in the morning. And we issued a second unit at about 4:45 in the morning. The nurse noted that the patient started to have hematuria during the second unit and stopped the unit. And shortly after she stopped that unit, the patient developed cardiopulmonary arrest, and asystole, and a code blue was called. The patient ended up coding a total of 3 different times and expired during the 3rd code. So immediately, the blood bank was notified that we may have had a fatal hemolytic transfusion reaction. And we did all of our serological workup that we do whenever you submit a transfusion reaction, and we have to rule out whether it's hemolyzed. Now, this is a complicated case because she had positive antibody on her red cells both before and after transfusion. Her antibody screen, she had positive antibodies in her plasma both before and after the transfusion. The cross matches, we went back and repeated them. They were compatible with that absorbed plasma that we were using. We had truly given A positive blood to an A positive person. There was hemolysis present both before transfusion and after transfusion, which is what you'd expect with somebody with acute hemolytic anemia. But you can see that the amount of blood present in her urine had gone from very small to very large. So we knew that the rate of hemolysis had increased. And even though we'd given her 2 units of red blood cells, her hemoglobin actually dropped from 7.7 down to 4.2. So she had gone into this accelerated phase of hemolysis that you sometimes see with autoimmune hemolytic anemia. We just did other tests to prove that there was hemolysis, which really weren't necessary. Her haptoglobin was less than 7, her lactate dehydrogenase was elevated, her bilirubin was elevated. We did not see a change in potassium, which sometimes we see with massive hemolysis. So what we had in this case was a definite temporal association of the transfusion with her cardiac arrest. We immediately assumed it probably was a hemolytic transfusion reaction, but in working it up, we couldn't find any evidence that she got incompatible blood, and we think that really was just an accelerated autoimmune hemolysis, and that when we gave her 2 units of blood, autoantibodies destroy transfused blood just as much that they do the patient's own blood, and we were just giving her increased red cell mass. She was hemolyzing more and more red blood cells, releasing all the contents of those red blood cells, and this precipitated the cardiac arrest. And also just the fact that she already had a history of mitral valve prolapse, and then she had a hemoglobin down to 4 by the time that she had the arrest. The incidence of autoimmune hemolytic anemia is about 1 in 80,000 individuals. It's more common in women, just like all autoimmune diseases are. Usually we see this in people between the ages of 40 and 60 years. You can classify it both as primary or secondary. Primary meaning there's no underlying disease predisposing you to autoimmune hemolytic anemia. Secondary, we usually see it in conjunction with lymphomas or lymphocytic leukemia, or with autoimmune diseases like lupus. Most of the time we'll see a positive direct anticoagulant test is how we diagnose it. And a lot of people think that if we report out our direct anticoagulant test is anywhere from negative to 1+ to 4+ in strength, and people have always assumed that if it's 4+, it's more severe than if it's 1+, but there's no correlation whatsoever between the strength of the blood bank test and how badly a patient's hemolyzing. The big problem with these cases is detecting these underlying antibodies. They're present in about 30% of patients with autoimmune hemolytic anemia because most of them have been transfused in the past. The autoantibody, like I said, destroys a transfused red cell just like it does the patient's own cells, but when a patient's hemoglobin gets really low, you don't have any choice but to try to support them. But we try to avoid transfusion whenever we possibly can. And in this case, I think you really want to try to avoid over-transfusion. Since this case occurred, I've always kind of tried to suggest that we only transfuse 2 units at a time and never more than that in 1 day's period, just so we can avoid this accelerated hemolysis.